Hey everyone, our group is the UCL Terriers, and we are presenting a case study on the UCL injury in a baseball pitcher and the potential treatment options for that injury. We hope you enjoy.
Here's the set. The 3-2 pitch, a wild pitch back to the screen. Saunders is hurt. A wild pitch because something in his arm snapped.
Sorry, Justin. Imaging has come back and seems like you have a torn UCL.
What is the best option?
Well, you have a couple of options, but first we'll need to go into some background information. My assistant here will direct you in that aspect.
Thanks, Dr. John.
These are our group learning objectives. Number 1, identify the most commonly injured structure in a UCL injury. Number 2, identify when non-operative treatment would be recommended. Number 3, identify the difference in intervention technique between UCL repair and UCL reconstruction.
Hi Justin, I'm also Justin. Dr. John has told me about your UCL injury. I'm going to give you some background information on what the UCL actually is. So along with the anterior joint capsule and the radial collateral ligament complex, the UCL is one of the structures that provides static valgus elbow stability in the overhead throwing motion. The UCL is fan-shaped and is composed of 3 bundles: the anterior, the posterior, and the transverse bundles. The anterior bundle is the primary restraint to valgus stress throughout the entire range of the throwing motion, but particularly from 30 to 90 degrees of flexion. It's the most commonly injured bundle in the overhead throwing motion. Repetitive tensile stresses causes the microtrauma and eventually the attenuation and the failure of the ligament. So Justin, now that you know what the UCL is, I'm going to give you some statistics on the UCL injury in pitchers. Among professional pitchers, Major League Baseball and Minor League Baseball, there are 497 active players with at least one UCL reconstruction. 437 of these players are pitchers. Among Major League Baseball pitchers, 25% have had UCL reconstruction.
Man, I wish I could ask this guy my burning question, but I don't want to sound foolish.
It's a safe place.
Oh, thank God you said that. So what your assistant just told me is that the anterior bundle of the UCL is the most commonly injured.
Yep, you're right. Next up, I'm going to have one of my favorite assistants tell you about non-surgical treatments for your injury. He follows me on Twitter.
Hey Justin, I'm here to tell you about some non-operative treatment options. Non-operative treatment for UCL injuries are indicated for low-grade partial tears, but they could also be used for high-grade to complete tears, although the return to sport at the same level is thought to be lower. So for rehabilitation, the initial 2 to 3 months, throwing is ceased completely. It involves cryotherapy, regaining motion, strengthening of the shoulder and scapular muscles, correcting deficits along kinetic chain, anti-inflammatory medication, and the use of long arm splint or improved range of motion brace at 90 degrees at night, where as needed to control pain throughout the day. If pain-free and range of motion is restored after 3 months, discontinue the use of the splint or brace. Progress upper extremity strengthening program to all muscle groups. Detailed regimen consisting of functional exercises, plyometrics, and interval throwing program may be completed. An elbow hyperextension brace may be used for throwing and lifting. After pain-free completion of the entire program, athlete may return to competition. A study found that non-operative treatment resulted in a 42% return to previous level of competition at an average of 24.5 weeks.
So your Twitter following assistant just demonstrated that non-surgical treatment is recommended when there is a low-grade or partial tear or when the athlete does not intend to return to play.
Wow. If I had a $20 bill, I'd give it to you right now. But here's a compass card.
Oh.
I'll have my number 2 assistant describe some common surgical techniques to you.
Hey Justin. Next up, I'm going to tell you about a couple UCL surgical techniques. So the first technique is going to be UCL repair, and it's utilized for acute tears of either the proximal or distal end of the UCL, and it allows for more aggressive rehabilitation protocol and earlier return to competition compared to Tommy John surgery. The other common surgical technique is UCL reconstruction, where the UCL is torn completely or severely torn, and it essentially has the same dissection and exposure carried out during UCL repair, but a graft is used rather than fiber tape dipped in collagen. And it's also called Tommy John surgery, and it's first performed by Dr. Frank Jobe in 1974 on Tommy John. This technique has undergone several modifications since 1974.
I didn't know that the ligament is directly repaired in the UCL repair surgery, whereas the graft is used in the UCL reconstruction.
I'm going to have my two most hardworking assistants tell you more about UCL repair and reconstruction. UCL repair has been abandoned for the most part due to the emergence and efficacy of UCL reconstruction, as well as the mixed outcomes of UCL repair. Two of the most prominent studies done reported a 50 to 63% rate of return to the same or higher level of competition in the UCL repair groups. Our group found that the majority of UCL repair studies indicated a lower rate of return to play than in UCL reconstruction, but were of low quality evidence. However, the focus had completely shifted to UCL reconstruction, so there were no high quality studies done to change the commonly accepted thinking. In more recent years, higher quality studies have revisited the idea of UCL repair. The most commonly cited one was a case series done to investigate the efficacy of UCL repair in young athletes who were hypothesized to have less chronic attritional damage. They reported that 56 out of 60 patients with a mean age of 17 returned to sports within 6 months post-operatively at the same or higher level of competition. They recommend primary repair of UCL for patients participating at the college level of play or younger, if the damage is at one or both ends and if the ligament is not extensively damaged. The recent large increase in UCL injury in younger athletes supports the application of these findings. Another study was done with cadavers, and it introduced a new technique of UCL repair that demonstrated similar biomechanics as UCL reconstruction, but with faster return to play. Clinical data is required, but this novel technique may supplant UCL reconstruction in the future.
The number of ulnar collateral ligament reconstruction surgeries performed on professional and amateur athletes and baseball pitchers has significantly increased in recent years. A 2015 systematic review found that the docking technique had the highest return to play at 97%, and the Jobe technique had a return to play of 66.7%. Overall, 86.2% of the patients in the study were able to return to play at the previous level, with a complication rate of 10.5%. Collegiate athletes have been found to have the highest return to play after an ulnar collateral ligament reconstruction. A different systematic review noted that ulnar collateral ligament reconstruction surgery allows athletes back to their previous level of play more than 80% of the time. For pitchers who have undergone the surgery, there's evidence that has shown that pitchers either maintain the same or lose a very small amount of velocity. Studies have shown that 83% of MLB pitchers are able to return to sport after the surgery, although they tend to pitch fewer innings, fewer complete games, and have less wins per season.
So with the evidence presented here, and with a compass card on the line, we would like for you to engage in a 2-minute conversation with your neighbor on the following question. Based on the evidence provided, what treatment option would you prescribe to our professional level pitcher with a complete UCL tear who wants to return to play?
Let's go over what we learned.
So in summary, the ulnar collateral ligament provides static valgus stability. The anterior bundle is the most commonly or frequently injured bundle of the UCL.
Non-operative treatment is a good option for those with low-grade or partial tears.
A graft is used in UCL reconstruction, and in UCL repair, a piece of fiber tape is used.
UCL repair has been recently revisited and is recommended for younger, non-professional athletes whose UCLs are not extensively damaged.
Ulnar collateral ligament reconstruction is a recommended treatment for professional overhead throwing athletes with a completely torn ulnar collateral ligament. The docking technique has been found to be the most successful type of surgery.
Hey Justin.